Thank you very much. Thank you.
Yeah. Well, thank you. I believe it's now everyone is here.
Yeah.
Well, I was prompted by my friend Salima, who I've been following for some time, to participate in this very interesting meeting, which I think is going to contribute to understanding the need for an index. I'm not going to question the validity and the soundness and the relevance of our index, but we can perhaps see whether the need for having such a discussion and such a measure as an instrument of measurement is going to be perceived as relevant. And I'm starting by standing on the point of history because of what happened to South Africa's greatest contribution to the world in the health of, in the field of health. We did not receive it can, but community-oriented primary care. Community-oriented primary care, which is South Africa's greatest contribution, and now I need to understand how this community will move. Whether I use arrows up and down.
The arrows.
Okay, not doing anything. Community-oriented primary care was initiated in South Africa during the period of modernization of the South African society, fronted by General President Jan Smuts in the very late 1930s and during the 1940s. But there is a history and a precursor for everything in the case of community-oriented primary care as well. We have to come back to the decade of the 20s of the last century, 20th century, and we have to come to China. The government of China embraced a process of modernization as well in the decade of the 20s. So by 1926, there was already an initiative in China that was called the MEM, the Mass Education Movement. And because of the cultural way of expressing themselves and using theater and dramatization, etc., it comes to our days like in the village of Jinjiang, Dr. Yin, one of the promoters of the modernization of China, Dr. Yin was approached by a peasant living in the village and said, "You know, Dr. Yin, I'm so glad I've been taught how to read and write, thanks to the mass education movement. However, when I go to bed at night, I go as angry as my neighbor who did not learn how to read and write." So that apparently prompted a process of analysis, of a holistic analysis of wider problems of the Chinese society of the 1920s. And after that analysis, they came to the 4 weaknesses of China by 1926, which were poverty, ignorance, poor health, and misgovernment. Unfortunately, they still sound very current to many places on earth, 20 or like 100 years after, 97 years after. And to the identification of those weaknesses, they responded with some measures. For poverty, the farm cooperatives, collectivization of exploration of the land. For ignorance, there was a school program continuing enhancing the mass education movement that was initiated prior to this holistic movement, and cultural programs with roving to theaters and going village to village. For poor health, there was a community health worker initiated that later was called the Barefoot Doctors Program. And for misgovernments, they created communes for the governing of their own wealth. That, for reasons that cannot be easily elucidated, the Rockefeller Foundation from New York put an eye on those changes and they sent Johns Hopkins graduate Professor Grant, who was called at the time the Rockefeller's Bolshevik, because the Russian Revolution, Soviet government was initiated in 1917, and everything that was progressive, left-oriented, socializing of any resources was sort of tagged Bolshevik. So Professor Grant was selected by the Rockefeller Foundation and sent to China, and he created in Beijing or Peking that time an institute for observing what was going on in the public health field with the modernization of China. Seeing that the process was yielding some positive outcomes, he invited Wits University graduate, Dr. Geer, who finished family medicine in 1928 in South Africa, Wits University, and they created what was called the Leicester Institute for Research in China. They were associating what we now call determinants of health as causative elements for identified diseases. The issue of lack of sanitation and swamps and agricultural development, intestinal parasites were linked. For the first time, hostile conditions were associated to epidemics of scabies and other infectious diseases of the skin and ectoparasites, and they start to produce a body of evidence of the relationship between causative environmental agents, which were socioeconomically determined, and diseases that were in nosological entities to be treated from the medical point of view. Dr. Geer worked in that institute tirelessly until he stays Klaver, a prominent South African public health enthusiast. We cannot talk of specialists, perhaps yet at that time. There was an incipient level of structure, pedagogically structured specialization programs, was made in charge of South Africa's very also incipient Department of Health as the Associate Public Health Officer. And Dr. Klaver, by 1925, called Dr. Geer from the Leicester Institute in Beijing and asked him to come to South Africa because there were promising changes with the intention of now racist, young smart evolving through Darwinian studies and principle of evolution into the holism that he later published. I need to make a parenthesis now, because it says that in 1937, the Sino-Japanese War halted the process of modernization that was initiated in 1926. Japan started incursions into Chinese territory in 1932, building small Chinese so big that they even noticed the little colony of Japanese and Japanese garrisons in the coastal areas. They were growing, polluting together. By 1937, the amount of Japanese forces into mainland China was big enough to halt the government of Japan, China, and everything came to stop. And I want you to keep that in mind. So the foreign invasion of China halted the whole process of modernization and intention of creating a socialized health care services. Coming back to South Africa in 1938, because of the tendency of modernization, and Jan Smuts also is to be given some credit for that, famous revered Professor Raymond Hart, one of the honorable members of the Felix Tobias, Raymond Hart, and Robert Bloom, South African renowned anthropologist that discovered the Australopithecus africanus in the Stilfontein caves. Professor Raymond Hart is vice chancellor, and he invites Henry Sykes, a famous historian of medicine, a public health precursor, and the person who published in the year before, 1937, socialized medicine in the Soviet Union that was igniting Johns Hopkins, Canada, as well as Wits University in Kenya. There was already a seed germinating in the context of Wits University, and there was this couple of boy and girlfriend, Sidney Clark and Emily Jaspan, who have already built up a society for the study of medical conditions amongst the Bantus. So Sidney and Emily have already seen that the patterns of mobility and diseases in the Bantu community was different to urban European communities, and they start to link the different mobility to the way of life and the socio-economic conditions that were governing the communities in which the Bantu community's life took place. But that time here, who was now back from China and instructed by Clapper to develop something, he came and joined forces with the Department of Health in Pretoria as the officer, the chief medical officer, and he called Dr. Blackman and made him in charge of a commission that was going to investigate the scenario of health and socioeconomics in South Africa and made a proposal. Dr. Blackman recruited Sidney Clark and Emily Jasper, who was later Emily Clark because they got married, and they created together the Blackman Commission that so famously contributed to hash the shell of what was cooking. That was a socialized approach to rendering healthcare, offering public health, or beyond healthcare, public health, based on the analysis of the different socioeconomic determinants. They built up the Blackman Commission. And by 1940, the Blackman report was delivered to the public. An excerpt of the Blackman report reads, a countrywide national health service funded through taxation and available to all sections of the people of this country according to their needs and not according to their means. So for the first time, they're saying universal access, funded by government and taxation, that's the source of funding, and based on identified needs, not based on access means, like I can pay, then I get it, I cannot, I won't get it. And that was very, very, very innovative, revolutionary for the time. The instrument or the institution that was designed by the Clarks to implement that at community grassroots level was called the Community Health Center. And the first one was elected in KwaZulu-Natal, Polela, in which a multidisciplinary team of professionals, including meteorologists, was invited to form part of the identification of and eliciting the community's need to be able to write recommendations that were going to tackle holistically all the health needs and provide services accordingly. That major contribution was followed by a transformation in the way of training and educating our professionals. So Professor Sidney Clark, not a professor at that time yet, say, if we take epidemiology and family medicine and we amalgamate them together, the family medicine will bring the rendering of care of medical services in a holistic manner, encompassing people living in families, like the male, the female, the adult, the elderly, the children, the pregnant woman, and everyone. But with epidemiology, will give them the orientation towards identifying determinants of health of socioeconomic nature, as well as natural, geographic, physical nature of the environment, put them together and find a methodology to improve the health of people, although also helping people to heal. They went out and Sidney Clark called it social medicine. He said that social medicine intended to create a social and cultural change towards social justice. And he made that famous, according to accounts of witnesses. There is a Chilean professor of COPC and family medicine who was disciple of Sidney Card in Jerusalem University. We'll talk about it a bit later. And he had interviews and recordings of witnesses of Sidney Card's intervention in the 1940s. He says social medicine will deal with the social and the biological issues. He says there are two types of diseases: the biological disease, and he exemplified. He said, Meneer van den Merwe lives his Standard Bank in Johannesburg, and instead of going home, he goes to a pub. He goes to the pub and he argues about liquor with his friends, and he drinks a lot of beer. When he finishes drinking his beer, instead of going home, he goes to a brothel and he engages in sex with a prostitute. In a week or 10 days after, Meneer van den Merwe is going to have syphilis. He said there is Tate Mokoena, who used to work in the mines at Monterrey and the development of the steel consortium there. They closed the mines and he's sitting in chapel by his doorstep. He see a flyer coming across, sounds like the grapes of wrath, very John Steinbeck type of description I'm giving you. And he sees in the mines in Carltonville, there is opportunity for work. He joins crowds of people, males going there. The army of people who are seeking for that illusion and that mirage that they're going to change their life. He goes to the mines in Carltonville and he's going to be hosted because it's far away from his native childhood. So now he goes on the ground, and when he comes out, the mining company offers him half his remuneration in alcohol and also brings a prostitute to the hostels to prevent him from taking anything far away and staying there for the next section of performance week. And in a week after, or 10 days, Tate Mokoena is also going to have syphilis. That was a socially determined syphilis, although the Triponema pallidum, the causative germ, is going to be the same. But the options in society, the options in life were different. Ones were not determined, the others were determined by the confounders of the socioeconomic environment. And then he carries on with that development of those paradigms and philosophical standpoints to develop social medicine as a specialist. In 1942, Koch is then named the technical advisor of the Department of Health, and he was commissioned to replicate the Polela Community Health Center model with this holistic, multidisciplinary participatory approach to primary health care in a socialized manner. And he continues developing that because the segregation policy, the access to medical school or health sciences was not easy for non-Europeans. So they were already cooking way to develop those approaches. So the process of modernization of James Mats was picking up. He was also engaged in the post-war, Second World War scenario with the drafting of the Constitution of the League of Nations, what we call today the United Nations in California. So he sort of was a bit stretched too far. But the Clarkman, Dr. Clarkman in the Ministry of Health, and Dr. Gale, who was from Seriben, by the way, from Everton Farms, was the chief officer. And Clark was then released from his administrative obligations to create the Institute of Family Medicine and Community Health as for teaching social medicine in Germany. Those who were not accepted to Wits University or to Pretoria University were then now flocking there because there was opportunity for non-Europeans to be trained and becoming medical officers with a different approach. That was a condition. We are not teaching you here the way you could have been taught in Cape Town, Wits, or Pretoria. We got a different approach, and bear that in mind as well for later discussion. And people were happy because they were having the opportunity to be trained. What's happened is that, another parenthesis after the 1937 Chinese altered transformation is that Grant, the ones that was the Rockefeller's Bolshevik, was instrumental after the liberation, independence of China in the Boer Commission for the creation or the policy making of the state of Kerala in the South China, India, where we know there is a socialized approach to the whole setup of the states, not only health. And he was instrumental in bringing this up. There is no clear or analysis why Rockefeller, such a wealthy magnate and followers, were so interested in socializing. My hypothesis is that being all of them Jews, they were already lobbying and creating the platform for the future state of Israel to have such a body of evidences and of methods and way of practicing for them to successfully thrive in a hostile environment in a limited amount of time. But that's a hypothesis, right? Because coincidentally, Kant is Jew, Jasper is Jew, Gear is Jew, Kant is Jew, Rockefeller is Jew, and they are bankers and they're full of money, and bankers never give you anything, not a pen. When you see you can go and take this pen from the bank, it comes from your account. So these guys, in the Board Commission in 1947, and I'm talking now in front of a historian, and I'm going to be classified, is the Kerala state transformation that we all understand today. Pairing with the South African situation, now we come that because Jan Smart was entertained with world affairs and his was perhaps a bit narcissistic and contributed so widely and went around so much, the National Party took over. They were also feeling a threat in the modernization because they saw a lot of, not only the Health Blackman Commission report recommendation, many other things were thought could be based on taxation. And according to the law, only white people were producing tax. So the 1948 National Party came and they say, we need to all stop the Blackman Commission recommendation. Okay? An internal force, a political lobby, a political organization that is seeking power, which finally obtain power, is halting that policy development. Okay? The Blackman Commission recommendation of providing universal access based on taxation to everyone, based on needs and not based on means. By 1949, there were already 44 of the community health centers that Sidney Clark was in charge of making nationwide. I think the only one surviving is Alexandra Community and University Clinic in Alexandra, because it comes from that time. By 1950, there was a decision to prosecute Dr. Koch, and I have come to 4 conclusions of how community-oriented primary care was altered and dismantled. First one is that the white population, now overwhelmingly empowered through the National Party, say white population is the only taxpayer and we are opposing the use of tax money to fund a health services or a public health system that will benefit everyone. First, no money for the process of implementing and developing that. Second, the medical fraternity, and this is something that I want to highlight, those who benefited because they were not eligible to be students of Wits University or elsewhere, and who went to Durban to the new approach, who benefited from being trained in medicine from the new approach. Now they say that fraternity withdrew the support in favor of the incipient private sector because there was a lot of money being produced. Remember, the post-war scenario was a feast of industrial and consumer development and consumerism. The motor car populated and plagued the cities and the towns and the highways. And so the vacuum cleaner and the washing machine and all these byproducts of the war effort that were coming out to the household. For the first time in the history of the family was disintegrated, and I'm going too far perhaps, as we understand it today. Instead of living together or very near, the family, the children now supposed to create a new household far away from the parents. Now you see that room, but it wasn't. It's a recent event of 70 years or so, because they needed you to buy an extra washing machine, another vacuum cleaner, another refrigerator, and another motor car. So all these industries created a number of casualties that was significant, and people saw a lot of benefits in the traumas and emergency accident. Even the victim or the victim, the donor of Chris Barnard's heart transplant was a motor car accident victim. So the beneficiaries of the new model, just years produced by, benefited by Sidney Carter, his approach. I'm going to teach you how to interact with the society to prevent a car accident. And perhaps public health measures should be in traffic control, speed control, signal, traffic signs, all these preventative measures. Now, the good thing is that people break their heads to show we teach them and charge. So there was a lobby amongst the medical class against being trained in a socialized approach to medicine. And that Sidney Carter could not circumvent. Another lobby was the nursing profession. Because of the lack of confinement to a health facility of the social medicine of Sidney Carter, you could have been now in a consulting room or in a household or in the middle of the plant of the crop fields. The nursing college and nursing fraternity said there was an inherent threat to status of nurses in the Polela model, because now the starchy uniforms were full of mud, and the contact with the natives and the difference in languages and culture, they felt overwhelmed and threatened, and they withdrew their support. So two main players, the medical doctors and the nurses, have withdrawn their support. And they are not external factors. Those did not come from Mars or another galaxy. They were indigenous individuals having a different standpoint. The fourth contributing factor to the stopping and dismantling of the experiment of socialized medicine was what Prime Minister of England, Winston Churchill, created in his paranoia after meeting with Stalin in one of both of them drank with vodka and Valentine whiskey and etc. He came with the paranoid thing that the Russians was actually in Stalingrad battle, not in the D-Day Normandy event. They are going to come for us. And there was this of communism initiated in England, very much taken by General MacArthur in the United States, and in South Africa there was an act for the suppression of communism. So Sidney Carter was unfairly and opportunistically taken to that judgment for a very funny reason, accused of allowing white doctors to smoke cigarettes in front of black nurses. That was an act of, I don't know, for those people was a subordination, like mingling, you know what they made the case is that because of that and the distributions of beans, blankets and resources donations to the indigent population in Durban around the Institute of Social Medicine, and this issue, very far-fetched of smoking with the white nurses, black nurses, etc., Carter feared that he was going to be persecuted, and he left the country for the United States. He went to California teaching social medicine. Nobody listened. So, being a Jew, being the state of Israel created, he jumped the sea and went to Jerusalem University, where he continued developing the methodology for social medicine. The world was ashamed of having so much industrial development and so little achievements in the field of public health and the rendering of care to communities with lacking access. The World Health Organization gathered in Alma-Ata, then the Soviet Union in 1978, and said, health for all in the year 2000 as a slogan, as a objective, as a goal to pursue, and the vehicles got to be primary care based on the teachings of Sidney Clark from the Jerusalem University, which was again based on the Blackman Commission and years experience in the Letter Institute and Professor Grant from John Hopkins developing this appreciation of what the Chinese were. By that time, far away, the Chinese have become the barefoot doctors because rice, field workers, rice is cultured in flooded terrain with water. They were barefoot with short pants, roll-up pants, and those were the very same people that were identified, trained to become community health workers and to carry out all the promoted, preventive, and strong traditional Chinese medicine curative features. Clark left, as I say, the Alma Ata Convention came, the world went after the pursuit of this of the objective of world of health for all in the year 2000 through primary health care, and it's only in 1980, so many years after, that Sidney Clark changed and decided to call it community-oriented primary care rather than social medicine as he did before. He coined the term, he minted it. He said COPC will integrate clinical knowledge with rigorous research methodology and social justice. And this is like the fourth time that social justice comes into this discussion. I said that the Chinese structural development and modernization, including health, was halted by the Japanese invasion. And I ask you to remember that. Well, after 1948, when China liberated from, and the Japanese were defeated and they became the republic, they immediately, automatically, with no external ignition or prompting or funding, reinitiated the process. Because they were aiming to allow social justice. So when I had this discussion and the ill-fated opportunity of developing South Africa's greatest contribution in the field of health, I have to also say, after becoming a specialist in the field, it's 37 years now, I came to South Africa in 93. It's going to be 30 years in a week time or so. 2nd May 1993. By the end of 1993, by December or so, I have already developed in one section of Botshabelo, a township in the Free State, that was at that time fighting for incorporation to Kwakwa, and they wanted to remain South Africa. Across the road of Botshabelo, there was the Republic of Botswana that was scattered all over the territory of South Africa, and they didn't want to be Botswana later, and they were behaving badly. So the organization for which I worked, Medicine Kumonda, sent me there. And then in 4 months or so, I organized fully fledged community-oriented primary care with the participation of the community workers that were trained, with the politic participation of all the forces of the community, and with the contribution of all the health workers. Talked with funding from the European Union because I was medicine. Because of that experience, that was singular. The late Dr. Molefi Paul Circular, who was the leader of the ANC for health in the Northwest, called me, and I said, tribal communities that were also, of course, fighting in cooperation to Botswana in Braklati and Nieuwfontein. And it took like 3 or 4 months to develop a sensible community-oriented primary care approach, because there was commitment to project justice. Because the experience kept on growing, I was asked to go to Nicaragua, Honduras, a coconut river of Mayan Indians communities, which are by nature Nicaraguans and Hondurans. And I developed in 3 months community-oriented primary care because they were aiming to allow social justice to flourish. I was so busy with them when they asked me for advisory work in Mexico, Quintana Roo State, in the rural areas, and it lasted like 2 weeks to do a few seminars and let people implementing themselves the experiment of community-oriented primary care. Growing that experience, Medicine Kumon appointed me a head of primary care developmental programs, because as an intervention in a non-profitable organization, they came to emergency situation. They took a few legs and put 1 or 2 water plants, etc., and they leave. and they leave chaos behind. So they were thinking that it should have been, they could be a smooth transition with primary care development, and they made me in charge of that. With that, I went to Brazil, Norway, northeastern Brazil, and in 4 months, I left community-oriented primary care work. My project of community-oriented primary care and social justice and social medicine in Botshabelo, different states, was halted, I think, the month after the elections, so by May 94, halted, because who was I to come and implement that? That was the first question I would ask. Then wise leaders of Gauteng province asked me, why don't you come to Gauteng? In the outskirts, we got this district of the Val and the Cinderella of Gauteng. It wasn't Gauteng, it was PWE, Pretoria, Westwaterfront and Vereniging. But okay, I accepted it. I entered the Val Triangle Sediment District on the 6th of February 1998. Since then until this morning, I have been trying unsuccessfully to develop a successful community-oriented primary care. I cannot blame individuals for that, but I have to come to the conclusion, and this is my hypothesis, that these are designed that primitive industrial capitalism, neoliberal design policies is not a lack of understanding, it's not a shortcoming of the intellect of those who are in power, because we don't have light that is shed onto what the health needs are. The district health information system in South Africa is extremely weak. So when you are a planner, a public health person, you have to rely on individualized, customized investigation researches or any type of device things, because the health information system doesn't yield any valuable information. And I have come to the conclusion that in a primitive industrial capitalist albinistic society that have embraced neoliberal policies, because of the individualized vertical relationship to even to God and the lack of communal. And look at, for example, there is claim for land distribution, but there is no claim for cooperatives. People want my land and they pray to my God. No, yours, you pray to yours. And is it the same? Well, I'm sure he's busy with me now, so it's not listening to you. We are behaving like there is one only mango left in the branch of a tree, and we need to kill each other for it, like gladiators in the arena. And that is neoliberal policy. So my very far-fetched hypothesis, I'm sure it can be refuted easily, says that the lack of interest and collective interest into achieving social justice is what prevents the upbringing of community-oriented primary care that was all the way called social medicine, which was aiming to allow social justice. Thank you very much.
Thank you.
Thank you. Okay. So first I want to say thank you very much, Victor, for your presentation. As you were talking, I just thought of the Letambula song, Not Yet Uhuru, that was just going on in my head, and the timeline, how you put it through. And on the point of universal health coverage, that a lot of the time the discussions are funding, and to just have that historic introduction so that we can understand the relevance of South Africa's contributions. Interesting in preparing for this, I was doing some deep dive, and I found an article that talks about the links of the Freedom Charter and health. And I found I'm very young. So interesting, I found out that there was this health charter campaign in 1985 And there was a publication in something called The Critical Health, and the author, they eloquently pointed out, and this was written around 1987, that, or rather warned that it's not just about a political change. That's not enough to transform health. Because what you showed there's so many political changes that happened, but much that what transforms health is I guess what's dominated by healthcare workers is that you also need to make sure that there's funds. So it's about money, but then also there's the political will to create those changes. And interestingly enough, even your care index, you talk about, we made this declaration in 2001, but what a 15%, South Africa is only about 38% of its health budget. And interestingly enough, I went on to look at another index on PhD. We spend about 60% of that budget on PhD. So where everyone thinks it's all about funds, what this made me conscious of is, okay, fine, we have a discussion of funds, but what are our personal narratives and our ideology and our politics and our own, could underpin what is our own philosophy towards socialized healthcare? So I wanted, and I know it's, when we think of economy, think about socialized. So I wanted to move a little bit from funding, but understanding that yes, the funding, but there needs to be a recognition of the need for socialization. And the fact that I think there's no recognition, for socializing anything, is that's why things are undeveloped, underfunded. And interestingly, with NHI, everyone's looking at Thailand. There's always, I've heard Dr. Chris talk a lot about the Thailand model, and partly it could be that no one has this institutional model of the timeline that you presented to us. And so, because I don't want to dominate the discussion, there's a few questions that I have, which are open to you or anybody else, is that then, whilst with your story and your career choices, and possibly a lot of the things, what are personal narratives that drive interventions and policies and the choices to prioritize primary healthcare, to prioritize COPC, much like what the clerks did. But then the personal narratives of the people that during that period before the clerks left, that destabilized it, because we saw that there was a personal narrative from the doctors who, with privatization, there was a personal narrative from the nurses, and how our personal narratives can do both good, okay, and our personal narratives can equally do bad in destabilizing what we're trying to achieve with the socialized healthcare. And it's very important because I put on then my cap of an educator, in that our healthcare training platforms, seemingly, then there's a narrative toward, we speak of the biopsychosocial model, but when you look at people and how they teach, very health-centric, institutions are happy to churn out specialists, but we're not community-based. And so the services of what we hear on policies, that we want a community-based healthcare service, a socialized healthcare, but is the health training of professionals, of healthcare professionals, where we speak lip service and give partly a sort of like a snapshot. We take students for a community exposure, but majority of the time it's just to say, oh, this is community work, and there's an aha moment, and everybody comes back and we say, oh yeah, it was so enlightening. But we then churn out graduates that completely, well, majority, and I don't have the stats as I speak here, but majority who don't have that commitment to socialized healthcare, that are keen to open up their own practices. But then the other question would be, what is in that graduate or in that individual that chooses to commit to socialized healthcare, even though they're just getting a snapshot? Because our healthcare training is not one that's rooted and community-based. because we don't have the Polela style socialized medicine of training. We are in the hospital, we are in these curative models of training, but yet there are still those that we produce that commit to COPC, that go on to study, work in family medicine, or choose PhD. So yeah, that's pretty much, I'll leave it there and give that a chance. So thank you.
Would anybody else like to come in, or would you like me to go? No, thank you so much. What an interesting interpretation of a broad field of knowledge, and then bringing your own passion and expertise from not only your time in South Africa, but also your own training and your own background before. So just like Daniela, to thank you for that and to respect you for that. And also to join with you in the present, looking back at your extreme sadness and frustration, which hasn't stopped your passion and motivation. And what was your exact phrase? Working from 1998 in Sydney all the way through to now, in an attempt to develop something which in some circumstances you were able to achieve in a number of weeks in Tapichaka, earlier on, and then in other contexts, which is regions of certain countries in Latin America and South America. So I suppose for me, and I do think that this links well with Daniela, and in the sense I'm sort of taking from you to Daniela to you, is that what is, I think, useful to thread into analysis, and which didn't come out today, but I'm sure it's in my other work, is the question of the form of state, the charterist through to constitutional aspects, although you did mention the role of Jan Smuts in formation of the UN Declaration of Human Rights. Most of what your discussion leaves out is the complex interplay between public institutions and administration, the form that a state takes, which is hinted at in your presentation, but it's not at the core of it. And then the framework of law and governance that goes along with that. And the impression that I get from many clinical spaces that I'm in is that while students are very open, and in my view, delightedly so, to the history of community-oriented primary healthcare, it's very undertaught in South Africa. Virtually nobody who has studied history, sociology, anthropology, politics, economics, law, let alone medicine, knows the story, as you well know. It's a huge effort to communicate it to people. There are hundreds and hundreds of books and thousands of articles written by South Africans, translated into different languages. Dr. Susanna Dlamini-Zuma herself grew up in Polela, was brought into the world by Nina Jali, tragedy of childbirth. The whole role of the Jali family, the role of the Salva family, the Phillips, and many others is very well known in the academic literature, but it's people in Boston and people in Jerusalem and people in London much more of this history than anybody can, which is a crying shame and it should be remedied. But one of the things that delights people when they find out about this is inspiration. It's something for this region of the country to ask why we'll be able to achieve it under these extremely non-propitious circumstances of segregation and then apartheid or earlier apartheid. How can we not achieve this now? The challenge, the critical challenge of that is it is story-based. It's based on strong individuals. It's based on the dramaturgy of anti-communism and of Smuts and Koch. But it only tells a small portion of the story. And the other parts of the story are much harder to get people to think about. And that involves how do you thread social justice into law? And how do you take a de jure practice and thread it into de facto public administration, public affairs, which is what this institute is devoted to? And how do you constantly bring measurement and evidence to bear? And how do you produce consequences for people not using resources for law policy mandates? So what's so extraordinary in some ways is to link to your narrative. In 1996, 97, 98, Dr. Susanna Dlamini-Zuma came to KZN many times. I was at the university there, the Health Science Faculty, Nelson Mandela School of Medicine, and the History Department. We held workshop after workshop on the history of community-oriented primary health care. Emin was still alive. We brought the Sassers, we brought the Jali family, we brought people from the Gidi family, we brought nurses and doctors across the country that were recommitting through the underground movements, through the ANC, through the Progressive Primary Healthcare Network and other banned entities in the 70s and 80s. We brought people together to recommit to district health that would be attached to and in conversation with the set of commitments that you've laid out to the community-oriented primary care. And the district health system, as you know as well as I do, was set up to try and be a legal framework that would speak to policy and resources and would actualize and bring into being these forms of care-based, community-oriented, responsive, preventative versus curative medicine. One of the things that, of course, nobody could have specifically planned for, perhaps, although I question that more as I get older, is the impact that HIV/AIDS would have on perverting some of the outstanding goals of that initiative. Again, you know this as well as I do, or better than I do. But one of the things that was easy to observe from Prince Natal is that as people returned from exile and before Prince was assassinated, I attended meetings with he and other exile people spoke about the tremendous threat, not only in the soon-to-be created new health system of HIV/AIDS, but the threat that they've observed in Zambia and other frontline states in East Africa to placing resources at the primary healthcare level when you were dealing with such a highly complex and at that point non-treatable community disease. And I was very interested to see recently going through the papers of the Alexandra Health Clinic, which I've shared a little bit with Daniela. We've had them all donated to us, that as early as 1983, Dr. Tim Wilson and many other people very closely aligned to the ANC and to the doctors movement, they were writing health policy statements about how what they still called social medicine, not that they didn't know that the name was becoming, in a sense, depoliticized in a way with community-oriented primary health care. What they were still calling social medicine and the ethics of care and democracy and radical health movements. They said this can be really difficult to achieve in South Africa if we do not deal with the sexually transmitted infections we've inherited over 100 more years, and with the rise of this new threat, which they named and which they said would be born as a heavy burden in the heterosexual community of African descent and not amongst white male gay drug users. And of course, they were banging on doors, pointing this out, and were bringing this up at meetings. Many secret meetings were held in the Val Triangle, at Wits, in the civic movement, in Alexandra Health Clinic itself. So the documents in Adelaide, look, they're handwritten, many of them have been kept by people such as Dr. Tim Wilson for 45 years in his house. And they document people saying, how are we going to navigate a highly infectious communicable disease and responses to that in an environment of moral censure, authoritarianism, lack of trust between people, and how are we going to build that into a critique of the political economy of the country? How are we going to raise this to the level of discussion and debate in the highest channels of power? And how are we going to bring this to the door of the migrant labor system and the mining industry? And, I think in the first flush of the 1993 constitutional negotiation period through to, let's say, about 97, 98, it felt strongly, and you would have been in the country, you would have felt it. And I'm sure that's partly what gave such enormous hope to you, Doctor, is that this is what the country was going to take on as its normative set of values, and that every single piece of public administration around health would be measured against indicators that produced better care, fair and just distribution of resources, the involvement of community boards and community activists in decision-making around spending, and a real sense of dialogical engagement so that health became a citizen good. It's absolutely clear by 1998, as I was pregnant with my daughter, I remember very well, as the death rates rose in KZN, and as doctors that you know very well, like Professor Jerry Kovadia, were risking life and limb to bring the therapy into children in King Edward and with the hospital in Durban, were being threatened publicly all the time as Thabo Mbeki was moving into the presidency. And in the build-up to the big AIDS meeting in Durban in 2000 in the brand new convention center named for Chief Albert Lutuli, when Thabo Mbeki delivered a set of injunctions about what he understood this calamity affecting the country to be, which he named as a conspiracy, as part of an international effort to destroy Black life, as part of an international effort to sexualize Black men in a demonic way, rejecting the advice of all of his scientists, the doctors around him, of people suffering in front of him, including Parks, his own spokesman. As that happened, it was really clear for us to see in KZN, the home of much of this experimentation, the horror reaction that was felt that Nkosazana Dlamini-Zuma would not stand up to him, that the second generation of health practitioners that he would appoint to the health ministry would not stand up, even though people such as Manju Shabala had been early advocates for dignified HIV care. I heard her give a speech at Valley Trust. I'm sure you know about that very interesting experiment in Valley of the Thousand Hills. I was present in 1997 when she actually gave a lesson to those of us involved in hospice care, what HIV is, how it's caused, how you could try and weave preventative and supportive forms of non-stigma-based feminist. She gave a feminist argument about feminist-based family care, about the needs of supporting grandmothers and the people for whom the burden of care would fall on unpaid women living in the informal economy. I thought she was absolutely tremendous. She was one of the doctors at the Valley Trust. I remember going home and telling my family, who is Manchu Shabalala Nisaman? She's an outstanding speaker. She's been trained abroad in exile. She's bringing a completely different understanding of the political economy of health linked to social justice. This is really going to animate the efforts that we're making to link public administration, public finances into district health, only to discover whatever it was. Less than 5 years later, my daughter and my other children were just, finding their feet in the world, that she was standing in front of me at public conventions saying any form of a link to, for example, the experimental drug Liripine is an act of sabotage. It is the third force. It will destroy African independent life. The remedies that we need are to be found in our soil. They include beetroots, which by the way are not indigenous to South Africa. They include this, they include this, and this. I could not believe it. And in that same phase, the perversion in the funding streams in the health ministries was starting to become extremely evident. So a long beating thought is that we have to attend to what the doctor has set out today for us as the inspirational core and the political core of our commitment to common humanity. The logic of it, the science of it, the evidence of it seems to me, and definitely seems to you, absolutely clear. But I cannot lay the blame for why we constantly fail to scale this mountain at the door of neoliberal foreign forces, because we have had the resources available, we've had the intellectual capacity, we've created the policies, and we've even trained cadres of people, you've trained many yourself, who are ready and stand willing to interact with this agenda. And why we are unable to do it, we have to start naming things: corruption, self-aggrandizement, the role of many of the doctors trained and nurses trained in this paradigm in setting up para-private facilities, the refusal to have responsibility and accountability for actions. How is it possible in the personal capacity that Dr. Manchu Shabala ended up in Donald Gordon Hospital receiving a liver that she was not entitled to, and then literally drinking herself to death? These are scandals. They are almost unbelievable that they could happen in this society. And if you don't weave this story in, especially in this building, if you don't build in the month after month, year after year, return to the fiscus, to the treasury, of money allocated for community-oriented primary health care. The two provinces I know best are this one. I don't know the data from Northwest or the Northern Cape or the Cape, but I know the KZN data all too well. One project I was involved in around community-oriented primary health care for children, just in the district of eThekwini. We returned 3 years in a row, more than 400 million rand just to the KZN Treasury for Health, because we could not find a way to ring-fence that money from being corruptly removed. And that was when Dr. Zweli Mkhize was NEC for Health before he became the Premier. I am aware of a tragic story of corruption and malfeasance that goes back at least 15 years more earlier to COVID. And it is not because we lack indicators. This compendium of results continentally shows us that South Africa suffers from many of the diseases of our neighbors. We have not been able, for example, to embed the notion of reward for care for people who are non-salary, who are non-status, who are not part of a governing political party, who do not have jobs that are central fiscus, whether it's in Zimbabwe or other frontline states such as Namibia, or whether it's countries further to the north and west of us. So one of the counter arguments, for example, to the CART tradition, the Jali tradition, the tradition that we've had laid out this morning, is that, of course, every body of knowledge is to constantly develop and be critical of itself in order to grow and to become fit for purpose. And when Emily and Sydney and Amelia and Edward and all of these other people, I just call them by their first names, were engaged with Gail and with Kluwer and with others in this project, they were focusing on the idea of a patriarchal family organized around Christian stewardship. And I'll wrap up here. And in that line of argument, the idea of a father protector in a family of faith that would be Christian, in sometimes polygamous, but certainly extended family unit, so not a nuclear family unit, that resources at the community-oriented level would mobilize through that structure. Of course, that's not the way that this ideology and practice was taken up in China for obvious reasons, or in other societies, but that was the model. In the 70s and 80s, quite rightly, in the South African development of the literature around this approach, there was a far deeper focus on single-headed households, on women bringing up children in the absence of present fathers, on the huge toll of which you refer to both with sexually transmitted infections and alcoholism and dependence on drugs and opioids, the enormous burden on men's bodies and the enormous feminization of clinical space so that men felt often alienated from receiving the care that they needed, and the bifurcation in an exaggerated bifurcation of gender differentiation in South Africa's indigenous communities, in the white community, in the so-called Indian and colored communities. This was noted. And so African feminist analysis was also brought to bear to community-oriented primary health care. But as you know, the genealogy that you draw in your work, it's there like a heartbeat in this, but it's in more broader work. And it is about how do you bring resources to the least visible of these structures. I can only end by saying that if Christian, 90% of South Africans are professing Christians, and about 62% of South Africa's clinics have some link to or connection to a Christian mission past. And although you emphasize the people of the rabbinical faith of Judaism, I think you've strongly underestimated the way in which the CARTs worked all the time with African Christians and with Christians such as Gera and Gail in their work. And the undergirding of certain forms of socialist or socialist leaning Christianity was really important to the confidence and the ethics of a certain kind of Christian socialism in this country.
No, I'm very familiar with the issue of progressive Christians that contributed to a socialist platform, even to the communist parties, etc. Mental Bolera, Basi Krishnasamy, perhaps you know him because you were talking about that time. He was my friend as well as Wilson. I was with him the day before Eugene Blunt went to the World Trade Center with the AWD in the drafting of this green book of policies for the energy. Now come to a pessimistic stage in my life after 60. Perhaps it's because of biologically, which I see that if there is no transformation of the paradigm, the beacon that guides the society, and people say, yes, we are going to embrace collectivism and social justice, and for that I'm going to cede a piece of my liberties and freedoms, etc., for the communal goodness, then we are not going to succeed because there is no reasonable geography not to be embraced. That is a big limitation. The society may pragmatically have accepted that people in charge of teaching or administering the health services, or even designing it, may enjoy medical aid themselves. And that's a major limitation. I said it in front of one of my speeches to the students, a professor, well known, I'm not mentioning his name, heard it. I said, everyone who is accepting a job in the training of health professionals or in the Department of Health have to surrender their medical aid and the one of the family. Your grandchildren you have now because then you go and hire your children's medical aid somewhere. And it was a month or two. I met Professor again and he told me, Victor, do you remember to say that? I said, yes, I do. So that night we were having dinner at home and I commented that. My wife told me, he's so right, but if you dare to do it, I divorce you. Because there is a threat to your survival in the way the services are conducted. So people will have to say, yes, I share your sentiments, but I cannot afford them. Because we have to come together as a unison to embrace an idea of collectivism. We bring the students from Cuba in a very well trained manner towards collectivism, and a year after graduation, they only think of Mercedes-Benz. Because this is what is inculcated in the values of the society, in the paradigms of the post-industrial capitalist society. Sorry, I don't want to prolong myself, but something is.
I want to bring us to something which has been suggested, but maybe more concretely helps us to understand what are the preventing forces to establishing socialized healthcare in South Africa today. And as it's common, we've gone to the legal structure and we've gone to the questions of formation of ideas, right, behind social medicine, and then the question of the individual motives of doctors, nurses. I want to remind us about what happened in that space of, say, 1990 to 98. As an anti-apartheid activist on the outside, we knew in the late 80s that whatever was happening at those private conversations was bad news. So in the international anti-apartheid movement, there was a critique, which was very marginalized, and then there was the jubilation. So by 1990, for example, there was a park named after Nelson Mandela in Montreal. And we boycotted the opening of that park and the renaming, because we knew that what the ANC was doing is sitting down with multinationals. And so this is not a foreign force. I don't believe that, whatever we want to call it, neoliberal capitalism, the shift in world capitalism, that is a global phenomenon from the 70s, and the way that South Africa joined into that as a very late achiever of independence in the continent was a foreign force. It was local choices that were made by what came to be the African movement. And part of that was accepting the rise of private healthcare this country. So even prior to the 90s, you had a public system of healthcare in this country. It was reserved for those people that were considered subjects, that were considered citizens at once. That had already begun to dismantle by the early 90s. And what the ANC did not block was the further development of that privatized healthcare. And fast forward to 2015, the ANC's health market inquiry itself showed that there are a total of 4 companies that control healthcare in this country from the moment of clinics to pharmaceuticals to health insurance, right? It's a very tight, concentrated group of capitalists, more than the US. Now, why would we expose that study, which we didn't, right? So the HMI final report suppressed all of that analysis in order to support the NHI as it exists today, the proposed NHI. And that is following a model that has been proven to be unsuccessful in the richest countries in the world, in Western Europe and parts of North America. It is a model where the public is paying the private healthcare providers to provide healthcare to the public. Now, how can that be sustainable, particularly in a country with such a long history of inequality, which we know affects health? So for me, you know, that is those dynamics are what underlie the inability of African governments to socialize care generally. So what we need is, I think, understanding these political and economic forces and then mobilizing around a different way to even imagine care broadly or socialized narrowly.
Well, as you spoke, I thought came to me to say that it would be difficult for them to dismantle it as the government through PIC, which sort of invests on behalf of the pension fund, it actually is a shareholder in Medicare and Mediclinic. So you might come up with dismantle something.
How did we socialize care in Cuba? All of those private companies were nationalized.
Yeah.
They became part of the public service. In this day and age, 2023, Africa, the most unhealthy continent in the world, the continent that is providing healthcare labor to the rest of the world, while it is in such shortage domestically, how else can we socialize healthcare?
So one of the things I quoted about this one index when it looks at primary health care is as much as it can say 60% is spent on KHC, what are we spending on?
Well, Catherine said that the money is going right back to Treasury.
Is it salary?
It's not being spent.
Some of it's going back to treasury,
Yes.
most of it's on salaries.
Yeah, the spending.
And so, I mean,
There's
if
no interest in it.
what are we spending on?
Yes.
Because and I guess what are we seeing
But
in
again,
this?
if I may come in, Chair, whatever happens here is covered by the lack of information. The health information system is full of biases. I have discovered recently that the improvement on the maternal mortality is partly attributed to the change of the formula in which abortion-related causes have not longer counted. Even if I report them, now when the information is entered in the computer, it's chucked out. Because we need to sanitize the indicators. We do not have prevalences, we cannot attribute direct factors or positive factors to the mortality. So whoever is in charge of this malfunctioning system is not being ashamed or exposed because there is no data. Let me tell you something that I missed, and I'm sorry. When we initiated in the VAR, there is a COPC in 2011, March, we put experimentally, because people do not believe that system is effective. We put a system to eradicate malnutrition, and by the end of 2011, we eradicated malnutrition in children. And I went all over it. We eradicated malnutrition. People said, if you change your car, you eat today, what are we having for dinner? By 2012, malnutrition was put back. Because the people who were in charge and who were supposed to implement, and those who were supposed to monitor and evaluate and guide and pay and administer, etc., were uncomfortable with the intensity of the way that COPC produces, because it brings evidence in front of your face, brings a mirror to say how ugly you are. And until you don't manage yourself, you are going to be looking ugly. So our default rate, our TV indicators are awful, but we have ameliorated the formulas in the computer program for them to be still awful, not that critical. So what needs to happen is we perhaps have to demand that is a truthful health information system.
Yeah. And this is another question. On this very issue of data and on evidence and indicators, as you've shown us, Dr. Victor, one of the most astounding, and I think this is truly unusual breakthroughs that collection of people, including Sydney and Emily, but not only them, made, is they had this psychosocial, economic, political economy, epidemiology model. It's actually very similar to what Harry says it does, or to think of another entity so we don't praise you that too much. If you think of some of the work that the Gauteng Regional Observatory would bring together with their mapping and their triangulation, and very similar to what we achieved, right? So we've got good practice. And they were so transparent about the data they were collecting. I've looked at the actual cards that they got their field workers to fill out, and they would place at the end of every week on the wall of a particular crossroads, onto trees, literally sometimes, as well as onto nets and clinic buildings, the results of the last week. Who is hungry? Who didn't get care in time? Who has, in this community, not people by name, numbers, how many people in this area are suffering from this waterborne disease? And then they would say in challenges, what can we do about it? You too can help. And the only place in the world that I know of where this level of granular detail is covered, and I've asked about Cuba, but I don't believe it's to this level, is China. Now, I'm not advocating a Chinese system in South Africa where there's no habeas corpus, where there aren't any individual rights, and where there isn't a constitutional protection. I think that would go against much of what South Africans themselves have voted for and wanted through our Charterist movement. But one of the things that struck me when I went to China is that in the division of metropolitan areas and district health, you will actually have like social workers or social health practitioners, I don't know what the Chinese words for this are, tasked with solving challenges in this area, and they sell, and they will include lists on the doors of places. There are 25 people suffering from alcoholism in this district. There are 42 families that don't have access to this and that. And you, as a public health official, will not get your salary if this is not solved at the end of the year. Now, I'm sure that there are perverse incentives there. Maybe people also hide data. Maybe when they don't achieve everything that they're set out to, because we know that dependency on drugs or alcohol is very, very difficult to remove. I don't believe that you can change that overnight. But what I'm trying to point out by jamming together the Polela type and Family Institute type and Grassy Park and Forwardsburg in Joburg, they had them, as you said, maybe 35 across the country by the end. Why I'm comparing that to contemporary China is that public officials were held to account. Money was shown. Why do people trust gift of the givers? Because I can go on my FNB app right now and show you what's happened with the money I gave them yesterday. Who is earning what in the entity? Where are their traps right now? How much money have they spent on salaries? What are they returning each month? Who is auditing their books? Which community members are on their panels checking this and that? That's the level of granular interaction you need to prevent this wholesale stripping. So I am not ignoring multinational forces, neoliberal capitalism, the role of people planning in institutes abroad, how they continue to control different forms of capital flows, structural adjustment, all of that. I'm not local capitalists. I'm looking at people in Durban, I can name them, they include recent ministers of health, who would set up private hospitals. And they would know that they could get this particular hospital for free because they had starved that hospital of money. So they would basically get a piece of land almost for nothing. So they and other doctors could set up a private eye clinic. I've written books about this. And these people then get moved to national cabinet. So unless we have some way of attending to the gap between de jure and de facto, between the policies, motivations, and the money spent and the outcome, I do not see how we can have genuine community-oriented. You cannot implement that in a system that is so corrupt. And it's remarkable that they were able to achieve what they did.
Again, apologies.
Yeah.
We'll take the last comment. Soon someone was still saying something. So we can just close because it's
I would like to say. And this distribution. I mean, I'm here in Catherine, but I'm going to bring it back to perhaps I'm considered an advocate for family medicine and primary healthcare practitioners. So Thailand introduced family medicine in the 1980s, but by 1990 they had gotten to universal health coverage, so it's like a 10-year space. And interesting, it goes to the socially accountable approach that you're talking about. It's pretty much with pedagogy in the way we kind of train family medicine practitioners, anyone PhD, clinical associate. And what I'm not seeing is a recognition of family medicine, of driving universal health coverage in Brazil, in China, in Thailand, in Cuba, if I have to be honest, to say that for a very long time, and some of our institutions in South Africa, which people consider to be the top faculties of health sciences, unfortunately, are very concentrated in urban settings. They are very concentrated in a very hospital-centric type of way of teaching. And small little pockets of interventions of driving social medicine and social accountability approach and working frameworks of coverage, for example, Kwanda in Stellenbosch, and certain COPC units in the city of Tshwane and in Msibe, not much recognition is given. And interestingly enough, our Department of Health, when we talk about universal health coverage, lies on the political will and the technical expertise. I'm always conscious of the fact that the technical experts seldom come from family medicine and a PhD. It's public health and certain specialisms, which I'm not taking away the input that our public health practitioners bring, but seldom, if we're trying to be socially accountable, very seldom are they in those technical discussions. And so that's one thing where I'm saying that if try to bring in those people who have taken themselves to be custodians or are champions of the socially accountable approach. But another thing that I want to say is that we who believe in the socially accountable approach need to hold these higher institutions of learning accountable. So we're not, you understand? So in actual fact, I sometimes think of family medicine departments as the lesser cousin. And so what are we then doing in making sure that these that we are driving even the teaching and learning around the socialized.
So, thank you.